Okay, good afternoon. So today we are going to continue with the cardiovascular system. We started cardiovascular system last week when we studied the blood, and today we are going to continue with studying the heart, and then the last lecture on the cardiovascular system will be when we deal with the blood vessels. Today's lecture is related to a virtual lab video and some self-assessment PowerPoint questions as well. So the heart is a central component in the cardiovascular system. It is like a pump, or actually it's a double pump that pumps the blood throughout the body, and it is located in the mediastinum. The mediastinum is part of the thoracic cavity, which is located in the midline between the lungs. If you look at this section here of the thoracic cavity, here's anterior, posterior. On either sides, there are the lungs surrounded by the pleura, which we have studied that previously. And then in the midline, the structures, all these structures, including the heart, are called the mediastinum. So it's a midline structure, and you can see how the mediastinum extends from the front, where there is the sternum, to the back, where there is the vertebra. So the mediastinum, including the heart, is actually located between two bony structures. And that's why when you do compression on the anterior thoracic wall in cardiopulmonary resuscitation, this will result in squeezing the heart and pushing the blood out of the heart in cardiopulmonary resuscitation, because there are two rigid structures, anteriorly the sternum and posteriorly the vertebrae. This is to give you an orientation about the heart, that the heart is cone-shaped structure. So it's like a cone. This is the heart here. These are the blood vessels, but this is the heart. It's cone-shaped, and a cone has an apex and a base. So it's like a cone set on or put on its side. Here's the apex. The base should face the apex. So that will be the base of the heart, like the base of the cone, and it is located posteriorly. The apex of the heart is formed of the left ventricle. Now, when you study in a simplified way the functions of the heart or the anatomy of the heart, they will always say that the heart has 4 chambers. There are 2 atria on top of 2 ventricles. This might be enough for studying either simple anatomy or for even studying the physiology. And this was probably derived from the idea that this is the lover's heart, and the heart has 4 chambers. So there's atrium, ventricle, and ventricle. This is the right side, and this is left side. Now, to convert this lover's heart or physiological heart into an anatomist heart, in order to know the orientation of the chambers of the heart, then first of all, you have to lay the heart on its side. So that will be the anatomist's heart to start with. There's atrium, ventricle, and ventricle. This is the right side, and this is the left side. So the first thing, you put it on its side, and then you rotate it in a clockwise direction. And that's how the actual anatomical heart will be like this. Most of the anterior surface will be right side. So that will be the right atrium, which forms the right border of the heart. That will be the right ventricle, which occupies most of the anterior surface of the heart, while the left ventricle will be like a narrow strip on top, and most of the left ventricle is present posteriorly. It forms the apex of the heart. The left ventricle forms the apex of the heart, but it is a narrow strip when you look at it on the anterior surface of the heart. And the left atrium is even only a small part of it can be seen here, a small auricle where you can see it here. But the main part of the left atrium is located posteriorly and constitutes the base of the heart. So the actual anatomical heart is in no way close to the lover's heart. You can see it here. This is the right atrium, and that is the right ventricle. You see that the right ventricle forms most of the anterior surface of the heart, and then there is a narrow strip of the left ventricle and the left atrium. Left ventricle and the left atrium, and the left ventricle, it forms the apex of the heart. This is the surface projection of the heart. You can see that the heart is not completely on the left side of the body, but 2/3 of the heart are located to the left side of the midline, yet there is 1/3 of the heart which is located to the right of the midline. That is the region of the right atrium, and even the part that is located to the left of the midline is mainly occupied by the right ventricle. So that would be most of this area here. Most of it is a right ventricle, although it is located on the left side of the body, because, as I mentioned, because of that anatomical orientation of the heart. There is a point which is very important to remember here, that is the site of the apex of the heart, which again, I repeat, it is formed by the left ventricle, and where you can feel the pulsations of the heart, which called the apex beat. And this point is located about 9 centimeters to the left of the midline, and in the 5th intercostal space, intersecting with the mid-clavicular line. So, in other words, it's just below and medial to the nipple, but because the nipple is not a reliable surface anatomical landmark, so we use bony landmarks. We have the mid-clavicular line, and we have 9 centimeters from the midline, or 9 centimeters from the midline, and we have the 5th intercostal space. Remember how to count the intercostal spaces. You feel the sternal angle, the mandibulosternal joint, and then you go to the either side, you will feel the 2nd costal cartilage, and then below it is the 2nd intercostal space, 3rd, 4th, and 5th intercostal spaces. This is the place where you can feel the pulsation of the heart. The heart is surrounded by pericardium. And here we have 2 layers of pericardium. We have the fibrous pericardium and the serous pericardium. The fibrous pericardium is very thick. It's formed of dense, irregular connective tissue, and it anchors the heart in its position. It protects the heart, prevents overdistension of the heart. The serous pericardium is the same as the serous membranes, or is composed in the same way as the serous membranes that surround other structures in the body. We have already mentioned the pleura, and we said that the pleura has 2 layers, visceral and parietal layer. So this is again, the pericardium again consists of 2 layers, the serous pericardium, a fibrous and a visceral pericardium. And also we mentioned that the lung is pushed into the pleura, so that the pleural cavity will become a very thin space containing a thin film of lubricating serous fluid. The same story is here. You can see the pericardial cavity, and the heart is pushing itself into the pericardial cavity. The heart is not located inside the pericardial cavity, but it is enclosed by the pericardial cavity. That is the serous pericardium. But the fibrous pericardium is another story. We don't have fibrous pleura or fibrous peritoneum. It's only present in it's an extra protective coat. Instead of having 2 coats, now we are having 3. And this one is an extra protective coat. But as far as the serous pericardium is concerned, it is like its structure is almost the same as the pleura and the peritoneum that we are going to talk about when we deal with the digestive system. Okay? And again, this pericardium is to lubricate, to reduce friction, because the heart is always beating. And I mentioned that before, that we need these serous membranes when there's continuous movement. Like for the lung, there's inflation and deflation. For the heart, it is always beating. For the intestine, there's the peristaltic movement, the distension of the stomach or other parts of the large intestine, for example. So this will reduce friction. So here you can see that this is the deepest part, that is the visceral pericardium, And actually, the visceral pericardium is part of the wall of the heart. It fuses with the wall of the heart and considered as part of the wall of the heart. That's why the other name of the visceral layer of the pericardium is the epicardium. As we have epicardium, myocardium, and endocardium. So it is the outermost layer of the heart. It is the deepest of the pericardium, but outermost layer of the heart. So that's why we call it the epicardium. And the fluid is located between the visceral and parietal layers. There's no space between the parietal layer and the fibrous layer. So the fibrous layer is fused to the parietal layer. Probably it's the same like when we studied the meninges. We said that there's the dura mater, and fused to it is arachnoid mater. If you look at it from one side, it's dura mater. If you look at it from the other side, it's arachnoid mater. The same story is here. If you look at the pericardium from the outside, you will find that it is rough and thick. This is the fibrous pericardium. If you look at it from the other side, from inside, if you cut it and reflect it, you will find that it is shiny, glistening parietal layer of the pericardium. And then there is the cavity, same as the subarachnoid space, which contains CSF. And then there is the visceral layer that covers the heart. So these are the layers of the heart. I have just mentioned that the outermost layer, the epicardium, is actually the visceral layer of the pericardium. And then we have the myocardium. This is the important layer. Its thickness varies according to the load that it should take, because it contains cardiac muscle fibers, and these are contracting and they pump the blood from chamber to chamber and out of the heart, and they constitute the bulk of the wall, as I said. Then we have the endocardium, and this is actually a thin layer of connective tissue on which lies the simple squamous epithelium, which is called endothelium. You will see that endothelium, I'm going to talk about this next time when we deal about blood vessels, that the endothelium lines the entire vascular system. So even the tiniest blood vessels, they are formed of endothelium. Like the capillaries are formed of endothelium. And then you add the coats to them so that you will have different types of veins and different types of arteries. But essentially, the lining of all the cardiovascular system is a simple squamous epithelium, which is smooth and prevents clotting of the blood and is called the endothelium. Chambers of the heart, these are the 4 chambers of the heart. We have just mentioned about them, but you should here consider that the heart, when we say that the heart is a pump, in fact it is 2 pumps. The right side of the heart, which is formed of the right atrium and right ventricle, it receives venous blood from the body and pumps that blood from the right ventricle to the pulmonary circulation. And in the pulmonary circulation, the blood is going to be oxygenated and returned back by pulmonary veins as oxygenated blood. So the left side, the left pump, receives oxygenated blood from the lung and then pumps it, the left ventricle, through the aorta to the entire body. It will be oxygenated blood. That is the systemic circulation. While the circulation that starts at the right side of the heart is called the pulmonary circulation. So the right side should be weaker. The right side, even the right ventricle, although it is thicker than the right atrium, but it should be thinner than the left ventricle, because the left ventricle has to pump the blood to the systemic circulation against the systemic blood pressure, which is 120 millimeter of mercury. So it requires a thick myocardial wall, while on the right side, it is pushing the blood, pumping the blood against the pulmonary circulation, or to the pulmonary circulation, against a blood pressure of 25 millimeter of mercury. So it is much thinner on the right than on the left. Now let's deal with each chamber by itself. The right atrium, it forms the right border of the heart. And this is understood because we say that you have to put the heart on its side. So all the right border of the heart is formed by the right atrium, and it receives deoxygenated blood from the entire body through superior vena cava, which brings the blood from the body above the level of the diaphragm, and inferior vena cava, which brings the deoxygenated blood from the entire body below the diaphragm. So these are two sources of blood that comes to the heart. In addition to that, the third source is called the coronary sinus. That is the opening of the coronary sinus here. The coronary sinus drains the blood that supply the heart itself. So the heart is always pumping. It requires a lot of oxygen, and it cannot depend on the blood that is present in the chamber as a source of oxygen, because it's a thick wall. That's why the heart has its own blood vessels, its own circulation, which is called the coronary circulation. And these are coronary arteries that drain by veins, and these veins collectively, the veins that drain the heart, the muscle of the heart, which is the active part of the heart that requires all that blood and all that oxygen, these veins of the heart are going to form a big blood vessel, which is called the coronary sinus, and like any other deoxygenated blood in the body, it's going to open into the right atrium. So the right atrium receives deoxygenated blood from the entire body, in addition to the heart itself, the wall of the heart itself. Okay? And there is a septum separating the right atrium from the left atrium. The left atrium is located behind the right atrium, and this septum has a thumbprint oval depression, thinning in the wall, called the fossa ovalis. This was an opening during embryonic time, where the blood moves directly from the right atrium to the left atrium. Because in the embryo, the blood that reaches the right atrium is oxygenated blood. It comes from the placenta, from the mother. Okay? And there is no need to circulate the blood to the lung, because the lung is deflated and there's no oxygenation in the lung. So the blood will pass through this opening to reach the left side of the heart, where the left side of the heart is going to pump this oxygenated blood received from the mother to the body. And then immediately after delivery, this foramen is going to be closed. If it is not closed, then it will result in what we call atrial septal defect. Now, the right atrium is connected to the right ventricle via an opening, which is guarded by a valve. This is called the right atrioventricular opening. And the valve has three cusps, three leaflets, and that's why it is called the tricuspid valve. Each of these leaflets is formed of connective tissue covered by endothelium. All the lining is endothelium, okay? And then the right ventricle. As you can see, the wall of the right ventricle, a little bit thicker than the wall of the right atrium. There is an interventricular septum here, separating it from the left ventricle. The right ventricle pumps the blood through a valve here, which is called the pulmonary valve. This valve is also called the semilunar valve, because again, it has three cusps, but these three cusps, each one of them looks like a half moon. You can see it here. This is a half moon. This is another half moon. So it is semi-lune, okay? Semilunar. So three cusps, semilunar valve, the pulmonary valve. When the ventricle contracts, it's going to push these leaflets away, and the blood will go to the pulmonary trunk. And then from the pulmonary trunk, it divides into two pulmonary arteries here. This is one of them, right and left pulmonary arteries. The left atrium is the chamber that forms the base of the heart. This is the view of the heart from behind. So that is the left atrium. It's the base of the heart. And the base faces the apex. It's opposite to the apex. And the heart is a cone. So that's why this atrium forms the base of the heart. And it receives oxygenated blood via four pulmonary veins. So they are veins, but they contain oxygenated blood. And the reason is that, by definition, an artery is a vessel that carries blood away from the heart, and a vein that is a vessel that carries blood toward the heart. So these veins they carry the blood towards the heart, but this blood is oxygenated blood. While the pulmonary arteries here, they carry deoxygenated blood to the lung, but we call them arteries because they are carrying the blood away from the heart. All other veins and arteries in the body, veins carry deoxygenated and arteries carry oxygenated blood, except here in the pulmonary circulation. But as I said, the definition, it is not the artery is not the vessel that carries oxygenated blood. By definition, the artery is the vessel that carries blood away from the heart, whatever that blood contains, whether it's oxygenated or deoxygenated blood. And then this atrium, when it contracts, it pumps the blood through another opening, which is called, here it's on the left side, so it's called left atrioventricular opening, and it is guarded by another valve which has 2 cusps instead of 3, so it is called the bicuspid instead of on the right side it is the tricuspid. Here it is the bicuspid, and because this valve, the 2 cusps of this valve look like the bishop's mitre, which is the headdress of the bishop, then it is called the mitral valve. The other name of it, the mitral valve. So the mitral valve, left atrioventricular valve, bicuspid valve, 3 names for one structure. Okay? Then the left ventricle. As we know that the left ventricle forms the apex of the heart, where you can feel it in the left fifth intercostal space at the midclavicular line, and it pumps blood through the aortic valve. This blood is oxygenated blood. The aortic valve has the same structure as the pulmonary valve. So it is a semilunar valve with the 3 cusps, with the 3 demi-lunes. Okay, semi-lunes. The difference between the pulmonary valve and the aortic valve is that just above the aortic valve, look at it here, this is a view of the heart from above. So this is the pulmonary valve, exactly the same as the aortic valve, 3 half moons. But here in the aortic valve, there, just above the valve, there is an opening, a small opening, ostium, for the coronary arteries. 2 openings, 2 of these cusps, they have openings behind them, and these are the openings that will allow oxygenated blood from the ascending aorta to nourish and flush the heart. The myocardium, okay, provides oxygen to the heart muscle itself. Coronary arteries. I'm going back to the myocardium and thickness. I have just mentioned about that, but I just want to show you here, this is a section, a horizontal section like this one, a transverse plane of the heart, showing part of the left ventricle and the right ventricle. You can see that the right ventricle is thick, but not as thick as the left ventricle, is 3 times as thick as the right ventricle. And the interventricular septum, which is present between them, belongs to the left ventricle. It has the thickness of the left ventricle, and so you can see that in section, the left ventricle is circular, looks like a donut, while the right ventricle is crescentic and looks like a croissant. And of course, the left ventricle is the thickest chamber of the heart. And the reason is obvious, it has to pump the blood to the entire body against a higher blood pressure, 120 millimeter of mercury. So let's follow the blood here. Blood is collected from the inferior vena cava, superior vena cava, and don't forget the coronary sinus. This is deoxygenated blood, that's why it's blue. All of them, all this blood is collected into the right atrium. Right atrium pumps the blood through the right atrioventricular orifice to the right ventricle. Right ventricle contracts and push the blood against the pulmonary valve to the pulmonary trunk and then pulmonary arteries. In the lung, the blood will be oxygenated in the wall of the alveoli, alveolar ducts, alveolar sacs, and then returns as oxygenated blood via the pulmonary veins, 1, 2, 3, 4, into the left atrium. And then when the left atrium contracts at the same time as the right atrium is contracting, it pushes the blood through the left atrioventricular orifice into the left ventricle. Left ventricle contracts, pushes the blood to the ascending and arch of the aorta, and then to the entire body. Now, how do these valves work? Now we know that there are two semilunar valves, and there is one bicuspid, one tricuspid valve. So 4 valves. Now let's deal with the atrioventricular valves, the valves that are present between the atria and ventricle, whether on the right or on the left side. They have the same structure, almost the same structure, but one of them is with 3 cusps, the other is with 2 cusps, and the same mode of action. You will find that in each ventricle there is a prominences of muscle fibers called papillary muscles. So this is an example of a papillary muscle. Muscle fibers, they project from the wall of the ventricle into the cavity of the ventricle, and from these there are like tendons, cords, tendinous cords attaching the muscle to the cusps of the valve. So these are called the cordi tendini, tendinous cords. They are made of fibrous tissue, like a tendon. Remember, the tendon does not contract, but the muscle, like the papillary muscle, it contracts. So what happens here? During contraction of the atria, the blood will be pushed from the atrium to the ventricle. And then during contraction of the ventricle, some of the blood tries to return back to the atrium. What prevents that is that it will push in front of it, it will push the cusps of the valve in front of it. But these cusps cannot evert because they are connected by cordi tendini, which will always pull them down, like the strings of a parachute here, against the pressure of air. So, contraction of the papillary muscle, that is during ventricular contraction, what we call ventricular contraction is called systole, ventricular systole. So during ventricular contraction, papillary muscles will contract, pull on the cordi tendini, they will pull on the cusps, and so the cusps will not open back, will not open in a reverse manner and allow the blood to return back to the atria. This is not allowed. So the only way that the blood can leave the ventricle, because there is increased pressure in the ventricle, is that the blood passes through the pulmonary valve and it pushes open the cusps of the pulmonary valve, the semilunar valves. This is the same on the right and on the left side, right atrioventricular and left atrioventricular valve. In other words, the patency of this valve is an active process because it requires contraction of papillary muscle and the pull on cordi tendini. So there's an active process in preventing prolapse or eversion of these cusps. I would compare that to you with the mechanism of action of the other pair of valves, the semilunar valves. Look at the semilunar valves. They are cup-shaped. When the ventricle contracts, like the right ventricle or the left ventricle, it will push the blood and the blood will open the valves. During relaxation, what we call diastole, ventricular diastole, some of the blood again tries to return back to the ventricle. And because the cusps are cup-shaped, then it will push the cusps in front of it, and the cusps will close like here, and no more blood is returning back. So here, the process is a passive process. It is not an active process. The competency of these valves, the semilunar valves, is done passively. As the blood is returning, it pushes the cusps in front of it and the cusps close. It doesn't require any contraction of papillary muscles. This is again the blood circulation. There are 2 circulations, as we mentioned before, 2 pumps. So in the systemic circulation, the blood is distributed by contraction of left ventricle. So the left ventricle contracts. When the left ventricle contracts, it pushes the blood to the ascending and arch of the aorta. The blood cannot return back to the atrium if this valve is competent, because as it's trying to return to the atrium, the cusps of the valve will not evert because they are pulled down by these papillary muscles. This is one, and this is another papillary muscle, and these are the chordae tendineae. Now returning to the circulation. Oxygenated blood goes to the ascending aorta, to the arch of the aorta, and is going to be distributed in all the arteries, which we are going to talk about next time. Conducting arteries, muscular arteries, and then smaller arteries called arterioles, and then it reaches the capillary bed. And then from the capillary bed, the blood is recollected by venules and small veins, and then to the big veins, returning back to the heart. This is called the systemic circulation. The other circulation is the pulmonary circulation, and here the right ventricle pumps the blood to the pulmonary trunk, pulmonary arteries. It goes to the lung, it's going to be oxygenated and returns back through pulmonary veins. The other circulation here is called the coronary circulation. This is the circulation that is dedicated for the heart. And these are two coronary arteries. Because they surround the heart like a crown, that's why it is called the coronary circulation, because they surround the heart like a crown. You can see here, this is the base of the crown, and these are the two other sides of the crown. So it's like this. Anyway, it surrounds the heart like a crown. That's why it's called the coronary circulation. And as I said, that the heart requires a lot of nutrition, requires a lot of oxygen. The wall of the heart is thick and cannot depend on the blood which is present in the chamber of the heart, taking into consideration that half of the heart, which is on the right side, even it contains deoxygenated blood, not oxygenated blood. So that's why it has to have its own circulation. These vessels, they connect with each other. What we call anastomosis. They open and they connect with each other. So if one of them is a little bit narrowed, then the other can compensate for that. So there is an anastomosis in the coronary circulation until a point is reached that no compensation is enough, and this will result in reduced amount of oxygen reaching the cardiac muscle, a condition which is called angina pectoris. And if this condition continues, it will result in death of cardiac muscle, what we call myocardial infarction. And if the cardiac muscle dies, then it cannot be replaced. We mentioned that earlier, that regeneration only takes place in smooth muscle fibers, but does not take place in the cardiac muscle fibers, and it only takes place for a limited amount in skeletal muscle fibers. So when it is replaced by fibrous tissue, then the fibrous tissue is non-contractile, and this will affect the function of the heart, and making things more dangerous if infarction affects part of the heart, which is called the conducting system of the heart. And this is let's say, it is the wiring of the heart. So if these wires are affected in the heart, then the electrical signal will be disturbed. Either it will be blocked, or there will be any type of arrhythmia in the heart if the conducting system of the heart is affected by reduced amount of oxygen and is affected by a myocardial infarction. So the conducting system of the heart, it consists of specialized cardiac muscle fibers, and these are autorhythmic. They can fire on their own. But usually in the normal situation, they are controlled by the autonomic nervous system, as we mentioned that earlier. So the sympathetic nervous system increases the rate of the heart, and the parasympathetic nervous and increases the force of contraction, while the parasympathetic system, it reduces the rate of the heart. So although it has its own rhythm, but it is controlled by the autonomic nervous system. This conducting system of the heart starts at a point here in the right atrium, close to the opening of the superior vena cava. So that is the area here is called the SA node, sinoatrial node, and it usually fires at like 70 per minute, and the impulse is going to be propagated. It is going to be distributed into the atria. The reason for easy distribution of the impulse is because if you go back to the histology of cardiac muscle fibers, they are connected with each other by intercalated discs. And one of the components of the intercalated discs are junctions that allow communication between cells. What do we call these junctions? Gap junctions. So there are gap junctions that allow communication between cells, and so all the atria, they will contract together because of these junctions in between the cardiac muscle fibers until the impulse reaches the lower part of the interatrial septum, where there is another node, which is called the AV node, atrioventricular node. And from there, the signal is going to be transported through a bundle of these modified cardiac muscle fibers called the atrioventricular bundle or bundle of His. And then the bundle divides into two bundle branches, right bundle branch and left bundle branch, and then they will be distributed into Purkinje fibers in the ventricles, and the ventricles will contract. The question is, why the signal in the atria cannot propagate directly to the ventricles? The reason is that in the heart, there is what we call cardiac skeleton, which is made of fibrous tissue. And this fibrous tissue, the cardiac skeleton, it allows the attachment of cardiac muscle, it allows the attachment of the valves of the heart, and at the same time, it acts as an insulator between the atria and ventricles, so that an electrical signal cannot pass from atria to the ventricles unless they pass through the atrioventricular bundle of His. So you can see here in this animation how the signal starts in the SA node, and as I said, the rate can be controlled here. It goes to the AV node, and at the same time, it's going to propagate in the atria, and in the AV node, it's carried by the bundle of His, which divides into right and left bundle branches, and then Purkinje fibers, and so the ventricles will contract from the side of the apex up, so that to push the blood up into the pulmonary valve, or through the pulmonary valve and through the aortic valve. If this system is affected, like in ischemic heart disease, then patients might require an artificial pacemaker, and you can have an idea about artificial pacemakers by watching this short video here. Let's deal with another point here, is about auscultation. Auscultation means listening to sounds inside the body, either auscultation for respiratory sounds, for example, or auscultation for heart sounds. And of course, here today we are more concerned about heart sounds. This is how the earlier stethoscope was introduced by a French clinician. The sounds that are produced by the heart, they result from closure of the valves. And these sounds are going to cause turbulence in the blood flow because of the closure of the valves. So usually we have two heart sounds. First heart sound, usually they refer to it as lub, and then the second heart sound as dub. And the first heart sound is produced by closure of the atrioventricular valves, while the second heart sound is produced by the closure of the semilunar valves. When I say semilunar, I mean pulmonary and aortic valve. And of course, these valves are located, all of them, they are located behind the sternum. But because the closure will cause turbulence of blood, and the blood will take the sound to the surface of the body, so that's why we hear these valves at different locations, away from each other. For example, when you want to auscultate, in other words, to hear the sound of the aortic valve, then you will put your stethoscope just to the side of the sternum in a second right intercostal space. Second left intercostal space is for the pulmonary valve. Fifth intercostal space, mid-clavicular line, is for the mitral valve. I'm just mentioning these for you, and you don't need to memorize them. These places, these what we call them auscultatory areas, just keep in mind, these auscultatory areas where you best hear the sound of the valve do not represent the anatomical location of the valve, but they represent the place where the sound can be best heard on the surface of the body because of the turbulence of the blood that is created by the closure of these valves. Otherwise, all the valves are located around behind the sternum and the midline. This is to show you the regulation of the heart rate. As I mentioned, that there is nervous control, autonomic, sympathetic, parasympathetic. Also, there is control by baroreceptors, which are pressure receptors located in the arch of the aorta and the carotid sinus. And also the heart rate is affected by hormones, epinephrine, norepinephrine, thyroid hormones, which will cause rapid heart rate, what we call tachycardia, if they increase, in thyrotoxicosis. When thyroid hormone reduced, it results in bradycardia, reduced in rate of the heart. Ions play a role, age, gender, physical fitness. I think that you well know that athletes, they usually have heart rates lower than the heart rate of the other people. This is to deal with coronary artery disease. I think I mentioned that just a few minutes ago. This is a section in the coronary artery. We are going to study such sections next time. And you can see how the coronary arteries become narrow because of atherosclerosis. And therefore, there will be reduced blood reaching the heart, resulting in angina pectoris or myocardial infarction. Coronary artery disease, of course, treatment of coronary artery disease. I'm just focusing on surgical treatment, but there are actually lifestyle changes to start with. Second, there are drugs are used for the treatment of coronary artery disease. And then there are the surgical methods by angioplasty or stenting. As you can see here, they pass a catheter. They usually pass it from the femoral artery. We are going to mention the femoral artery next time. So the catheter is passed to the femoral artery against the flow of blood up to the ascending aorta, and then it is introduced into the coronary artery. And as you can see, the tip of the catheter will become inflated. They inflated by a balloon. Look at the atherosclerosis narrowing. They inflated by a balloon, and so they will retain the original size of the artery. If this was not enough, then they will leave a mesh, which is called a stent. So this is another way of doing it. They push a balloon, they inflate a balloon, and then they leave a stent. Or if all this is not enough, then they are going to do what we call a bypass grafting. So this is, for example, a bypass. They bring another artery of the same size or another vein, and then they bypass the site of obstruction. If this is the site of obstruction, then they will connect this artery distal to the site of obstruction to compensate.